Hello, my name is Jeffrey Frank. I am a clinical professor of emergency medicine at the University of Alberta in Edmonton, Alberta, Canada, and a visiting professor in disaster medicine at the University of the Piemonte Orientale. My clinical practice is approximately one half adult emergency medicine and one half pediatric emergency medicine. And I hold a master's degree in statistics and a master's degree in disaster medicine. It is my pleasure today to speak to you about current issues in pediatric disaster medicine. Objectives of our talk today is to understand how children can be disproportionately affected by disasters, to detail the unique biological, psychological, and social needs of children during disasters, and how hospitals can address them, and to list the basic components of a disaster plan for a pediatric emergency department. And also, we will today note the striking lack of evidence for most of what we do in disaster medicine. Just briefly to talk about the scope of pediatric disasters, since 1900 there have been over 9,800 natural disasters which have affected 67 million children worldwide. And in the event of a disaster, we should note that all hospitals may receive children. And because of their unique physical, developmental, and psychosocial characteristics, caring for children is different than caring for adults. Approximately 1/3 of disaster MCI victims are expected to be children, and children in general tend to fare as badly or worse than adults in disaster situations. We note that mortality rates during disasters are highest for children who are less than 5 years old. In the literature, it is well reported that healthcare professionals do have difficulty in dealing with children during disasters. There's emotional obstacles, there's unfamiliarity with pediatric physiology, there's struggles with the triage rationale, and then there's the efficiency in which often it just takes longer to care for pediatric patients. There is some research in the literature, most of which is consensus-based, and this is a very good article on hospital guidelines for pediatric preparedness, which has been prepared by the state of New York. It was developed between 2005 and 2007, and it's a consensus statement that involved approximately 50 members, including pediatric emergency medicine, pediatric critical care, pediatric surgery, social workers, emergency managers, and subspecialists. And this is a very useful document that you can download off the internet if you're interested. In this particular document, the authors detail 13 issues, and you can see them here. And we're going to talk about a number of these issues today, in particular decontamination, equipment, the use of the Family Information and Support Center, psychosocial considerations, security, surge considerations, training, and triage. We're going to start with decontamination in children. A lot of these issues come up when we think about decontamination of victims of a disaster. How do you keep the families together? How do you encourage shy teenagers? It's unlikely that you're going to be able to ask teenagers to undress completely, stand in the center of the room while people hose them off. Can children self-decontaminate? And if so, which age of children can self-decontaminate? And when do we have to do it for them? How do we prevent hypothermia? I live in a relatively cold climate, and many disaster plans involve decontamination outside. That is not going to be viable for children in most parts of our emergency department. And what if family members are also contaminated and cannot help? Who's going to help these children? These are all issues that we have to think about. Now, the New York City guidelines provide this very nice algorithm that describes how patients of various ages can decontaminate. You can see that non-ambulatory patients, of course, follow one route, and then ambulatory patients follow a route depending on their age. So there's a separate route for school-age children, who are usually able to decontaminate themselves like adults do, preschool children, 2 to 8 years of age, and infants and toddlers who are less than 2 years of age. What's the brief summary? Well, we should make sure that in pediatrics, for decontamination, we use high volume, low pressure sprayers. And from there, the decontamination will vary a bit as according to their age. So we will have patients who are infants or toddlers, and they will need to be placed onto a bed and undressed. Clothing will be placed in bags. And family members, if they're available, should accompany the child through the entire process. If they're not available, then usually we should have a single staff member who can accompany this child through the entire process. We advise the caregivers not to carry the children. Okay, caregivers will often want to hold the children in their hands while they're walking across a slippery floor. And we do not separate the caregivers from the patients unless the caregivers have critical medical issues where they cannot go through. In general, the trend now in pediatrics is even when the children have critical illnesses, we invite the family to be with them. For preschool children, we will ask them to undress. Again, they will stay with the caregiver at all times. And if they're ambulatory, they will walk through. Otherwise, they will be placed on a stretcher. And then for school-age children, we will usually be able to have them undress themselves. And we work very hard to respect their modesty and privacy. And children in this group can usually decontaminate themselves, often with the caregivers present. One of the things that we see in many disaster plans is that the plans rely on the fact that patients will be decontaminated at the scene. And in many cases, this involves a plan that states that emergency medical services will go out to the scene with their decontamination materials, decontaminate the patients at the scene before they come to the hospital. Now, this is a picture of a typical decontamination, a mobile decontamination unit. And you can see that regarding the guidelines for children, that it's virtually impossible to decontaminate children using this device. What all hospitals need to be prepared for is the fact that children may be more likely to arrive at the hospital without decontamination. They may arrive directly, fully contaminated, and need decontamination at the hospital. Second issue that is talked about in the New York City plan is about equipment. Now, we should note that equipment shortages are quite rare, except in large disasters. During Hurricane Katrina, family members apparently were asked to manually provide bag valve ventilation for patients when there was insufficient number of ventilators. And as such, the U.S. Joint Commission recommends 96 hours of self-sufficiency for hospitals. In the ice storm in Canada in 1998, this is a good example of what can happen to your hospital. There's a very nice narrative about the Brockville Psychiatric Hospital, which, because people in the community had no place to go, they had no shelter, and they quickly found that the hospital became a shelter for those without heat at home. And by the first day of this ice storm, this hospital was already experiencing equipment shortages. And because there was, in many places, an inability to move equipment around, it was very difficult to get additional equipment. We should consider having a type of pediatric-specific disaster cart in our hospitals. And the New York City plan gives some specifications for this. For instance, they recommend that there should be 2 infant and 2 child ambu-bags, 6 ET tubes of each size, and 2 laryngoscope blades of each size. The plan specifies, however, that this chart is the recommended amount of equipment expected for every single critical pediatric patient of unknown age or size. So we see here, because with pediatric patients, the The size of pediatric patients varies so much from neonatal to school age that we need much more equipment than you would expect with adult patients. And if you look at this chart, I think it's very likely that many hospitals will not have sufficient equipment to deal with a large number of pediatric casualties. So in our planning, we have to be wise to the fact that pediatric equipment will likely be needed in a larger volume simply because of the variety of sizes of pediatric patients. It is sort of a normal maxim in disaster medicine to generally use our disaster plan as a plan that we would have for approximately 120 victims and to rehearse the use of unfamiliar equipment. Unfortunately, many hospitals now bring their equipment in a type of just-in-time delivery, where daily or even multiple times daily equipment arrives at the hospital with just enough equipment for the hospital to function until the next equipment drop-off. Now, what do we do in a disaster when these just-in-time deliveries are inhibited? Or when we simply need more equipment? Will the vendors be able to supply this additional equipment? So this is something that all hospitals need to think about during their disaster planning, and is certainly even more so among pediatric hospitals. How do we mitigate supply shortages? Well, through preparedness, through conservation, through substitution, through adaptation, through reuse and recycling, and through reallocation. And these, as you can imagine, are things that we probably need to practice ahead of time, or at least have developed a plan ahead of time. How are we going to conserve, substitute, and adapt? One of the more striking differences in adult and pediatric disaster management is the Family Information and Support Center. The main functions of this support center is to provide accurate information, to provide psychological support for family members, to enable medical staff to concentrate on the treatment of casualties and not have to have the medical staff serve as the information center, to provide temporary childcare, and to protect families from the media. Now, during the 911 attacks, many family members went from hospital to hospital looking for their family members. And this can be very difficult. For instance, in Hurricane Katrina, families were evacuated out of their states. And so families had difficulty reuniting. A maxim is to expect approximately 4 to 5 family members for each child victim, and to remember that many families will go directly to the hospital searching for their family members. The use of information is very important. Timely information is very important, particularly in pediatric disasters, as this helps the victims and their family to regain the sense of control, and it reduces the sense of uncertainty. What's essential? What information needs to be out there? Well, the circumstances of the event, how the casualties are being evacuated, to which hospitals the victims are going, and then there's this victim identification stage where we start to find out who the victims are. And I think a very important piece of information that I believe we sometimes neglect is what didn't happen. So simply when a disaster occurs, telling people where the disaster didn't happen, telling them which airport it did happen, where it didn't happen. That can quickly alleviate many, many people who will be worried unnecessarily if they don't have the actual information. The Family Support Center is a very unique liaison between the public and the hospital system. And because of that, it has requirements for a certain structure. So the structure of the Family Support Center requires a capability to contact the public by phone and internet, and it really should be physically separate from the emergency department. For pediatric disasters, we may very well need a photograph or ID room that allows families to identify the victims. There should be consultation rooms, and we should have this pediatric safe area. What about children who come to the hospital who are uninjured but are not with their families? In adult victims who are ambulatory victims, we may say to them very quickly, you can go home, see your primary care provider, or come back to the emergency department later. But what do we do with ambulatory uninjured children? We can't simply evict them from the emergency department. I think there is in the future going to be a very big role in technology in helping with this type of communication, technology to help families reunite, technology to provide this information. Psychosocial considerations are again an area where we really need to think about the unique characteristics of children. There is often an assumption that children are more resilient. Children can adapt more quickly than adults. They can learn more quickly than adults. But this basic assumption may actually be inhibiting our abilities to provide them with treatment. The rate of post-traumatic stress disorder may actually be very high among children. We know that child abuse often escalates following a disaster. We know that restoring normative behavior can be as effective as counseling. And we must be sure that treatment is both culturally and age appropriate for psychosocial considerations. Now, post-traumatic stress disorder is the most common pathologic response to disaster among children, and the highest occurrence tends to be when the parents also exhibit symptoms of post-traumatic stress disorder. We can expect up to a 40% incidence, and in most cases we see symptoms develop within 3 months of the event, and these symptoms can persist for years, as I think we all know. Following the Oklahoma City bombing, it was cited that 50% of local elementary school children exhibited symptoms. And following the September 11th attacks in New York City, up to 75,000 public school children had symptoms of PTSD. And after the 1999 Athens earthquake, 78% of childhood victims developed PTSD symptoms. So we see that PTSD is very common among childhood victims of disasters. What are the risk factors? Well, intense or prolonged exposure to a disaster, either witnessing or sustaining an injury, perceiving a threat to themselves or to a loved one, other major life stressors that may be pre-existing can also predispose to post-traumatic stress disorder, having traumatized parents, disruption of daily routine, and intense television exposure, which I think we really, really need to concentrate on the possible downsides of the media. We have excellent media coverage now for disasters. Information travels quickly, and children are able to absorb this, and we have to monitor their exposure to this information. What are protective factors? What protects children from developing PTSD? Well, strong support from family, school, and community. Parental coping and thus parental support. Economic resources for the family. Of course, some of the prior items, such as prior low levels of anxiety, positive adaptive behaviors and coping skills, prior academic success, and then do children have the ability to understand the event? Children who can understand the event tend to have less incidence of PTSD. One of the common things we do in disasters is this post-disaster debriefing session. And one of the things we need to be aware of is that the actual evidence for psychological debriefing is poor, and that there's some evidence, in fact, that there may be an increase in rates of post-traumatic stress disorder in those who receive this psychological debriefing intervention. What does that mean? Well, it probably means that we as providers need to provide more. That simply talking once with children about what happened and then setting them out to resume their normal life is probably inadequate, and kids probably need more. And this is going to be the field of the psychologists and the psychiatrists and the mental health workers to provide this type of support. Security is an issue in many disasters, particularly mass casualty incidents with large numbers of patients. But in childhood disasters, there's also some additional considerations. Save the Children has identified 7 critical types of protection that children require in disaster areas and war zones. So this includes protection from physical harm, protection from exploitation and gender-based violence, protection from psychosocial distress, protection from recruitment into armed groups, protection from family separation, protection from abuses related to forced displacement, and protection from denial of children's access to quality education. Now, one of the things to remember is that hospitals do commonly become safe havens for unaccompanied children. So these may even be uninjured children who simply are brought to the hospital because they are without their families. Now, how do we match children to the parents across the hospital system? And how do we track accompanied and unaccompanied children? And where in our hospital do we develop this safe area for pediatric patients? This is a very common type of disaster. Many of us build into our disaster plan the assumption that the plan must be able to function without electricity, without computers, without technology, because we need to be prepared for that. So we use such things as these scene triage tags, and often we use such things as patient charting that is simply blank, anonymous charts that we're able to use quickly, and therefore we do not rely upon computers. However, as you can see, matching this type of information when a parent comes in and when a child comes in, maybe they come to different hospitals or different areas of the same hospitals, how can we match them using this type of technology? Now, there are many patient tracking systems for mass casualty incidents. There are commercial solutions, and there are also many hospitals that have developed their own. And I think one of the important things to remember is that most disasters will not leave the hospital without electricity and without computer systems. And we need to be prepared for the more likely problem of being there with a system that could work but not having it. Most of them work on radio frequency identification tags. They can involve barcodes that can be used right from the scene, and then computer systems that involve tracking by barcodes and even tracking by photographs. A very interesting commercial solution is this mother-infant tag, for instance, as an example of a system that might be useful, where these tags are put on the child and on the parent, and when they are brought together, they beep to confirm that you've brought the right parent to the right child. And I think that we need to look further into the future on the use of technology for this type of security. Surge considerations. Now, surge capacity is intricately and probably fundamentally related to disaster preparedness. And I like this quote from Barbiche in Koenig and Schultz textbook of disaster medicine that says a fundamental issue in disaster response is the need to provide appropriate patient care and public health support as demands for medical and health resources exceed existing supply. And this is, in essence, surge capacity. We need to be prepared in hospitals for two types of surge capacity. We may have a slow, gradual onset, a slow, progressive rise in demand for surge capacity. For example, we might have influenza. Or we might have a rapid but unsustained need for surge capacity. For example, during the ice storm or during a train accident. And both types can put a huge stress on the hospital system. A very nice description from Koenig and Schultz Disaster Medicine is this modular approach to surge capacity where we look at stuff, such as supplies and equipment, staff, and these are staff including physicians, nurses, all types of support staff, and your structure, which includes facilities, clinics, even mobile structures. And then over top of these three pieces develops this system of surge capacity. A interesting construct is to think about both surge capacity and surge capability, with surge capacity being where we are providing our usual services to a large number of patients. So this would be, for instance, I had the experience of working in the emergency department during the 2008-2009 H1N1 pandemic in Canada, where we provided our usual services, which was treatment of influenza, treatment of pneumonia, but to a very large number of patients. In contrast, surge capability is talking about providing a new or expanded service. So these are your patients that need decontamination, and maybe your department has never previously dealt with contaminated patients. There is, in general, a substantial lack of pediatric-specific surge capacity research, and this is a topic of research that is going on in some areas, including a research project that we have ongoing at the present time, which is detailing whether existing surge capacity metrics are adequate for pediatric surge capacity planning. Staffing recommendations. Another problem encountered and one identified frequently in the literature of disaster planning and response was the organization of on-site volunteer physicians. So this is a description from the July 17th, 1981 Hyatt Hotel Skywalk collapse in Kansas City. And as a physician, I find this particularly disturbing to see the words "another problem" and "volunteer physicians" in the same sentence. But in effect, we as physicians are often problematic in the organization of staffing. What does a staffing plan need to have? Well, a staffing plan needs to have an organizational structure. I believe that staffing plans should have job action sheets to help people know what they will be doing in their staffing plan, and then a list of standard operating procedures. Now, organizational structure of mass casualty incident response, of disaster response, is frequently based on Incident Command System. Incident Command System was born in 1968 in California, and it was originally used as a management plan for California wildfires. Since then, it has been successfully used for organization of disasters of all size. Certainly, I don't think most of us need to memorize these 12 principles of Incident Command System, but one of the major things that we see in here is step 1, which is the 5 primary management function. And then for physicians particularly, we need to look at number 7, which is unity and chain of command, and number 8, which is manageable span of control. It is those principles that are often difficult for us as physicians to understand and that can make key differences in our ability to use our staffing effectively. Why do we need an organizational structure? So in 1968, when the first ideas behind Incident Command System were being generated, this were the problems that led to this. While lack of accountability, there was poor communication and poor use of the communication modalities that were already there. There was a lack of an orderly planning process. There was no predefined method for interagency cooperation. There was working in silos. And for those of you who are not familiar with this term, a silo being these large vertical structures for storage, usually of animal feed, these structures tend to build themselves up vertically without communication with one another. So we often see the fire department developing one plan, police developing one plan, emergency medical services developing one plan with no communication. And we see a lack of common terminology. These were the problems in 1968 and tend to be the same problems that we're having now. Now, the Hospital Incident Command System is a way that we can develop very quickly a staffing plan for an emergency department or for a hospital, and it includes organizational structure and templates for action sheets. This is a typical hospital incident management team, a hospital incident command system organizational structure, and it really adapts incident command system for hospital use. This follows all the rules of standard incident command system, and it uses the ICS language. And so it's a very good start for development of a hospital disaster plan. There is, however, a problem with the hospital incident command system, and it really is about incident management. And you can see if you look closely that the medical care branch director is one red box, and underneath it we see the casualty care unit leader, who is the leader for all of the care of casualties. And we see that in the hospital incident command system, there's not very much development of the organizational system that goes on below that. So many of us who are on the ground providers will find we are left a bit hanging by hospital incident command system. One of the items that we have been working on is a incident command chart for emergency departments, which we call ICED, Incident Command Emergency Department, which is a very simplified version of Incident Command System for use for patient treatment in the emergency department. And it involves a charge physician and then physician leaders for the various treatment areas. And this is something that is available on our website for any of you who are interested. Job action sheets, I believe, have been a major contribution that came out of Incident Command System and out of the Hospital Incident Command System. And these are pull-out, mostly checklists that the staff in the event of emergency department use to detail their duties. They usually have some sort of mission statement. They talk about the reporting structure, and they usually give step-by-step instructions about what to do in the case of an emergency. I believe this represents the future of disaster management, as it is very, very difficult to train people in these job roles and expect them to remember this in the event of a disaster. Because disaster response entails many new jobs that simply cannot be remembered. And then a third part of your staffing plan should include standard operating procedures. And these are checklists or flowcharts for how to do these novel procedures, these things that we don't do on a regular basis. How do we activate the disaster plan? How do we evacuate our department? How do we do our disaster triage? And these need to be specified in the disaster plan. Following very quickly from staffing comes training. Training in disaster medicine is a very big topic, and it is typically one of the most visible aspects of disaster medicine. Full-scale exercises have been for basically the history of disaster medicine the type of gold standard of disaster rehearsal, of practice. And they certainly play a role. They are expensive to hold. They involve massive recruitment of facilities, but can be excellent educational programs. Some things you simply cannot find in other ways. Here you see a video of a carpet that is used as the floor of a field hospital, and on top of it you see the wheels of the stretchers. And you can see very quickly that the wheels of these stretchers cannot be rolled across this carpet. And this is the type of learning that full-scale exercises are fantastic for and often necessary. For really getting down to how do we train both patient care and logistics, the combination of full-scale exercises with high-fidelity simulation can be used. In which case we see in this picture an infant that was evacuated by the pre-hospital team to a field hospital, and we now see the resuscitation team acting on this infant. Computer simulation is a way that we can avoid many of the costs associated with live exercises. At our business, we are firm believers in computer simulation, and many of our group has worked in simulation using the Surge Sim computer simulation exercise. One of the things we ask ourselves is, do we need to rehearse all the routine parts of our job? Do paramedics need to rehearse driving the ambulance? Do emergency physicians need to rehearse intubating a patient? Computer simulation can involve stripping out these routine parts of our job and instead focusing all our exercise on the novel parts of disaster response that we don't do on a routine basis. Training in pandemic preparedness, for instance, is a very important topic, and our group is also looking with the analysis of influenza preparedness in Canadian pediatric emergency departments. And then finally, a question that we need to ask in training: is the problem how we are teaching, or is the problem what we are teaching? On the left, you see a disaster plan. This is the written disaster plan for a pediatric hospital. And on the right, you see the computer interface that allows you access to basically all knowledge that humans have ever collected. And we see how complicated the interface is for our disaster plan and how simple this computer interface is. In many ways, I think our disaster plans look very much like this 1957 encyclopedia. They're monolithic tomes, they're difficult to use, and we're trying to teach people how to use them. And I think we need to look also at what we are teaching. Do we need to revamp our idea of what a disaster plan looks like? And then finally, I will speak briefly about triage. The New York City plan details a type of triage here, which I think is very effective. It involves a visual assessment by visual assessment officer, a decontamination, a repeat visual assessment, and then triage to a resuscitation area, emergency department area, or fast track area, which I think could be very effective if this is the type of triage you use on a day-to-day basis. I believe that expecting our experienced triage personnel to pick up this diagram, having never seen it before, and attempt this type of triage in the event of a disaster may be fraught with problems. Many disaster triage tools, such as START and JumpStart, these have been designed for use in the field, and most have not been tested or validated for use in the emergency department. And we believe there might be a huge advantage to keeping the usual hospital triage system. And we have done a simulation study and a publication on the use of a two-stage model, which involves basically the use of START as a pre-department triage, which will be done basically in the ambulance bay of the emergency department, followed by the usual system of triage of the emergency department. This allows us to capitalize on the experience that our very experienced hospital triage nurses already have. And here you see the diagram of what we will use in the event of a disaster, which is an external triage outside before coming into the department. Patients will be triaged using START with also the discretion of the triage nurse or triage physician, at which point they will be registered, go through their own internal triage, and allow us to treat them as emergency department patients in the emergency department, how we usually do on a day-to-day basis. So I hope that this very brief presentation has allowed us to understand how children can be disproportionately affected by disasters. We've talked a little about the unique biological, psychological, and social needs of children during disasters and how hospitals can address them, and should enable us to list the basic components of a disaster plan for pediatric emergency departments. So that concludes our discussion of current issues in pediatric disaster medicine, and I invite you to look at our other online learning lessons on our website at www.medstatstudio.com or on our YouTube MedStat Studio channel. Thank you.